We're just going to give it a few more seconds for folks to come into the room, and then we'll get started. All right. Good morning and welcome back to our third webinar in our four-part webinar series focusing on value-based care. In today's webinar, we'll be focusing on accountable care organizations. Before we get into today's presentation, I want to address a few housekeeping items. First, please mark your calendars for our next webinar, which will be at the end of this month on Tuesday, June 27th at the same time frame from 10:30 a.m. to 11:30 a.m. Next, we encourage participants to actively engage in today's discussion by directing your questions to the Q&A section. We will do our best to address every question. For those we may not have time to answer, we will address them when we post our webinar recording. We have three great speakers at today's webinar. Our first speaker, Sandy Nesson, serves as the Chief Operating Officer for Community Care Partnership of Maine and Vice President of Operations at St. Joseph Healthcare. Bringing her experience in healthcare and health insurance operations, she currently sits on the Policy Committee for the National Association for Accountable Care Organizations. Our second speaker is Eric Burton, who holds dual roles as the CEO for Adirondack Health Institute and interim CEO of the Adirondacks ACO. With over 25 years of experience in healthcare, financial, and operations, he has successfully navigated organizations through rapid changes and challenges in healthcare systems. Named in the Albany Business Review's CFO of the Year class in 2014, he continues to lead strategy and policy implementation in the Adirondack region. Our final speaker, Dr. Keith Mueller, serves as a Gerard Hartman Professor in Health Management and Policy at the University of Iowa and the Director of the Rural Policy Research Institute. With over 240 published scholarly articles and policy papers, he has received recognition from the National Rural Health Association, the Rural Policy Research Institute, and the University of Nebraska. Among his achievements, he has served on national advisory committees and developed content for significant health initiatives. These speakers will provide you with unique insights into the world of health management and policy, drawing on their wealth of expertise and experience in their respective areas. We're looking forward to the valuable information and perspectives they'll bring to our discussion today. And at that, I'll turn it over to Sandy to start today's presentation.
Great. Thank you, Josh. Thank you to Josh and to Tom and to the team at Northern Border Region Technical Assistance Center for allowing us the opportunity to present today and to share a little bit about our accountable care organization, the unique design and approach to the work that we take in supporting rural healthcare delivery organizations in this work. So with that, you can go right to the next slide for me, please. Actually, the next one, we'll talk a little bit about who we are and what it is that we do. So this first slide gives you, Community Care Partnership of Maine on a page, or our attempt to place the complexities of the organization on a page. I'll start with the mission statement, and I won't read the mission statement to you, but I'll focus on some key components of it. So first is that we focus on collaboration and resource sharing, implementation of best practices. That's really the sort of construct of the work and how we pursue this work. And any of the services that are provided by the organization, developed by the organization, it's all done in the framework of what is now referred to as a quadruple aim. So previously the triple aim and now the quadruple aim, focused on how do we improve the overall cost, how do we reduce the overall cost of care, improve the quality of care being delivered and resulting the outcomes for our patients receive, as well as, excuse me, phone call coming in, as well as improving the patient's experience of care and and lastly, and importantly, not least importantly, improving the experience of our care delivery team members and providing that care. On the right-hand side of this page, you'll see an outline of the organization. So in the middle bottom, you'll see the composition of membership. This is something that makes us unique in terms of ACO structures. We are comprised of 19 otherwise unaffiliated healthcare organizations. So we have 15 federally qualified health centers, as well as 4 community hospitals that come together to form Community Care Partnership of Maine. On the top middle, you can see the way in which our organizations span the state. Again, this makes us unique in terms of the average ACO structure. We did not design or set out to control or influence a specific region of the state, but instead to attempt to engage organizations serving some of the most rural and remote areas across the state in this work. And that's really what we've been able to successfully do through the collaboration and membership. In the top left-hand corner, you'll see the contracts and agreements that we currently have in place. So not only do we participate in the Medicare Shared Savings Program and have for the past 6 years, we also participate in our state's Medicaid program. It's called the Maine Care Accountable Communities Program here in Maine. And then we also negotiate agreements with a number of commercial as well as Medicare Advantage plans to do value-based care, value-based improvement work. The top right-hand corner gives you a nice indication of the success that we've realized in these agreements across contract types. This specific number represents just our success in the Medicare Shared Savings Program over the last 6 years. So you can see the total aggregate savings that we've realized for Medicare over those past 6 years. We are fortunate to be one of a handful of accountable care organizations who's received 6 years of consecutive success in realizing shared savings over those 6 years. And then you can see in the smaller font underneath the 55 million here, the 24 plus $1 million that's been returned to our member organizations and shared savings as a result of that, just that one agreement. Bottom left, and this is where we'll place our emphasis, is the total patients served by our member organizations annually. And we'll talk a little bit more about why that is on the next slide, but 275,000 patients served annually across our 19 healthcare organizations. And then in terms of members that are ultimately attributed to us or attributable to us underneath an agreement, it's right around 120,000 lives and growing by the day, it seems, for those contracts. Next slide, please. So I referenced the heavier emphasis on the total number of patients served each year. And the reason for that is that another key aspect of our organization, something that makes us unique, is that we take an attribution agnostic approach to our work. And what that means is that we don't focus solely on those patients who are attributed to us or ultimately attributable to us underneath a contract agreement, right? We don't focus solely on those patients who we have a financial interest in improving their outcomes, but we made a commitment from day one, from the inception of the organization, that any of the resources, service lines, work that was pursued by CCPM, by the ACO, would act in service and in support of any patient that's served by any of our member organizations. And at the time, that was an altruistic commitment, right? We wanted to ensure that any of the things that were developed by the ACO aligned with our mission and act in furtherance of true population health. But we've found over time that, and unknowingly at the time, right, it was as much strategic as it was altruistic, because not only did it ensure that we aligned with our mission and our goal of furthering population health, but it also accounted for things like fluidity and attribution. We weren't singularly focused on that file coming over of here are your patients that you need to impact and influence care on. We were focused on any patient that was served by our organizations. It also resulted in an enhanced adoption of best practices that were identified or rolled out across the ACO. And I think that was largely in part because our providers and our provider team members came to see the ACO not as another entity that was focused on, furthering the efforts of a payer or meeting a payer designated metric, but as an organization that was really focused on partnering with them to enhance the care or to otherwise support them in providing exemplary care to their patients. And so rather than receiving, as many providers do, a workflow that is, if this is an Aetna patient, please refer them to X care management services. They would receive support to have an embedded care manager who would then act and support it across any of their patients that were in need of care. In terms of data aggregation and integration, so because of that attribution agnostic approach, we can't rest on our laurels, so to speak, when it comes to data. We can't simply receive the data files from our payers and work those files. And it's required us to be creative, but I think ultimately has landed us in a spot of having what is best in class access to real-time data. We are fortunate in the state of Maine. We have access to a really robust health information exchange system where all the hospitals in the state have their data rolling up through that health information exchange, and it's refreshed every 24 hours. So it's as close to real-time data as you can get. So that in combination with access to our member organizations' EMRs provides the data that we rely upon to do our work. We're not relying on 30-day-old claims data. We're able to see, again, any patient that's served by our organizations, not just those that are actively attributed to us. It also acts in furtherance to providing really high quality reports to our organizations that are already clean, right? They're not receiving claims data related reporting that may need some cleanup, that there's been a gap, that may need patients removed from the denominator, et cetera. That's all work that our team is able to do before it ever gets to the member organization. In the bottom left-hand corner, I'll talk just briefly about our shared governance model. We have organizations that range in size from an organization on an island in Maine that has less than 50 employees to organizations with upwards of 1,200 employees. Part of our design is that each organization is provided one board spot, one board seat, and each board representative has an equal voice and an equal vote. That really drives a culture of trust and engagement, commitment to population health work across organizations. It ensures that our hospital partners and our federally qualified health center partners, are treated as equal and are at the same table sharing information and hearing from one another as to what matters most to their respective communities, patients, and to their organizations. Last is our approach to providing centralized support and care for local care delivery models. Oftentimes, accountable care organizations develop service lines that are centralized and remove or otherwise centralize resources that had previously been local care delivery resources. Things like embedded care managers become a centralized team of care managers. We've really focused on trying to develop service lines that act in furtherance to the local care delivery team members, act to bolster and to support them, but also acknowledge and not only acknowledge and recognize, but also recommend the importance of having embedded local team members. So an example of that would be care management. An expectation of membership across the organization is that you have local care managers, folks who are intimately familiar with the communities that they're serving, know how to navigate social health services, medical health services, et cetera, and are embedded within the primary care practice. They are then bolstered and supported by centralized services at the ACO level that identify patients who are in need of outreach or intervention, that provide them with best practices in terms of providing some of that care management support to those patients. But it's that connection back to the local resource. Next slide, please. So this next slide, I won't spend too much time on this. It just gives you a walkthrough of what a standard contract agreement might look like for our organization. We often will negotiate some sort of per member per month payment that's designed to support investment in the work, whether it's staff that our organizations or that CCPM may need to put forward to execute the agreement, to operationalize the agreement. We will also then negotiate opportunities for shared savings based on risk-adjusted utilization benchmarks and also minimum quality targets. And then some of our agreements also include incentive payments for things like per member per month payments linked to quality targets, as well as quality bonuses tied to to payer-specific initiatives of interest, things like appointment agendas that we're all familiar with, or annual wellness visit completion rates, things like this. Next slide. So I just want to touch briefly on some of the benefits of membership in CCPM. Next slide, please. In the top left, and I'll go across here and just highlight very quickly, we have ample opportunities for collaboration that drive population health priorities. If you look at our composition of membership, as I referenced, we are otherwise unaffiliated organizations, but that doesn't mean that we don't have a robust and rich history of collaborating with one another to act in service and support to our communities. So you'll see in our history and in the organic sort of collaboration that occurs within our partner organizations, we have federally qualified health centers and community hospitals that have a long history of collaborating in ways that are unique for our state and our regions. And so we very much benefit from that infrastructure already being in place and being able to build off of that. The ACO acts as a statewide voice representing primary care in Maine in many ways and in many different forums. And that can be a benefit to organizations, particularly as it pertains to primary care, which is often an under-recognized voice in our state. We are well positioned to pursue and manage large grant projects. And so it allows us an opportunity to, again, collaboratively pursue grant projects that several of our organizations may have hoped to pursue individually, but in the absence of support and administrative support or otherwise. We have access to robust data sets, so it makes us an attractive research partner for organizations that are interested in identifying and spreading best practices in population health work, quality improvement work, or otherwise. We do provide a resource repository to our organizations. We look for redundancy in terms of work that's occurring across organizations. Where the majority of our organizations are independent, they're not part of a larger system, so they're having to generate much of their work locally. We look for opportunities to share and not to recruit the wheel when it comes to things like policy and procedure work, infection prevention work, these sorts of things. And then, of course, we reference some of the centralized services as well. Next slide, please.
All right, and Sandra, I just want to give you the friendly 2-minute warning.
Thank you, Josh, appreciate that. Next slide, and I think I can wrap up. Centralized services, this is just an example of one of the centralized services that we provide. It's comprehensive pre-visit planning. So it's focused, again, how do you reduce that overall administrative burden on the care delivery team locally so they can focus on providing care to their patients. And then when they're entering the room for that visit, they have everything teed up for them and ready to go. We've ensured that patients who might need lab services, other things like that, done prior to the visit that's already been completed. Next slide, please. These are some of the goals and benefits of that service, what it helps us to achieve. And then I think last slide, please. Next one, sorry. Last slide. So just to wrap up, how does this position us and our organizations for success in the long term? So first is being part of the ACO allows the member organizations to be part of the design of value-based purchasing contract structures, right? So we work with our organizations to understand what's important to them and embed that within the way in which we're developing those contracts with payers, with our state, and otherwise. We have an opportunity to continue to build on our centralized models. So to look again to what do these organizations who are predominantly rural and serving some of the most vulnerable populations in our state, what do they need to further be able to sustain and enhance the care that they're providing, and how can we be nimble and responsive to that need? And then the last is that we have the opportunity, and you can see it articulated here on the right-hand side, to continue to embed the quadruple aim in the way in which care is designed and delivered throughout our state and throughout our organizations. And I'll wrap up there. Thank you.
Okay, thank you. Can you hear me okay?
Yes, we can hear you, Eric. Yep.
Yeah, all right. Again, thanks, Josh and Tom and the team for the opportunity to speak here today about the experience in the Adirondacks. Again, I'm Eric Burton. I served two roles, dual roles in the Adirondacks as the CEO for AHI and the Adirondacks ACO. I think very common in rural health. We all wear multiple hats. And so I'll take you through our journey in the Adirondacks. Next slide, please. So for our history and timeline, we do call this the value-based payment journey. It is certainly a marathon and not a sprint. We've been at this work for about 10 plus years. I won't read through every piece here in this timeline, but just some highlights. We began in 2010 with the Adirondack Medical Home Pilot, which was a 5-year multi-payer pilot, which included New York State at the table with us. We formed the legal entity for the Adirondacks ACO, and in 2014 entered the first of our 3-year MSSP contracts with CMS. In 2015-16, we extended the medical home program, and then in 2017 to 19 range, we started to enter into upside and downside risk arrangements with payers outside of Medicare. Moving into more of the pandemic phase, an interesting kind of success story, I would call it, is under the COVID response. We served as a project management and data resource for one of our partner organizations, a hospital who was named as one of the vaccine hubs in New York State to roll out of the vaccinations. And so we served again as a project management kind of backbone organization to help that hospital through the rollout of that vaccine hub. And then as we look at the future, some challenges, as I'm sure most are seeing, how do we prepare for more downside risk? And that's something we are struggling with. On the MSSP side, we have taken advantage of staying on the upside only and starting to think about how do we prepare for that down the road. Next slide, please. A little bit about the Adirondacks ACO from a regional and network perspective. We serve 7 counties in the northeastern New York portion of the Adirondacks, 21 primary care practices, 60 sites, includes a large FQHC with 21 sites across our service area. We have 5 hospitals, 3 of which are under the University of Vermont umbrella, and 2 of those are critical access hospitals. One is currently a CA, one is going through that conversion process now. We also have a very interesting relationship with the Northwinds Integrated Health Network IPA, which is a behavioral health and SUD organization bringing in 12 providers across the region. And then in 2020, we began reaching out to CBOs and integrating them into our network. And so we started with our first contract in 2020. As it continued that, we've been lucky enough and had success with one of our payers where they have funded us $250,000 a year to enter into CBO type relationships and bring in the social care needs into the ACO. Next slide, please. As far as demographics for the Adirondacks ACO, we have about 137,000 attributed lives across the North Country. Almost half of those are in commercial contracts, about 49%, 35% in managed Medicaid, and 16% in the MSSP program. We don't really do much in the Medicare Advantage line of business at this point. We have one program with it's a little bit of a quality base. But we don't do much in the MA line at this point. For our value-based payment contracts, we have a combo of the types of relationships. We have upside only. We have these tagged here in green. The green and red is our upside and downside risk. And then we have several that are still just a quality based. You will see that in each one of these, with the exception of the Medicare, we do have embedded in this includes a PMPM that we have from the payers that flows into the ACO. We keep a small portion of that for administrative infrastructure and then pass the rest back to the providers. Again, a great success story for us. We have about $9 million annually that flows through to the primary care practices to support care management and other activities in their practices. Next slide, please. So here, I just wanted to talk about how we brought AHI and the Adirondacks ACO together. So one of the challenges we were having in the early days were how do we build a sustainable ACO infrastructure over a vast region, with a pretty dispersed population, and we had two population health vehicles in the region. We had the Adirondack Health Institute, which was a very grant-based organization. We have about a dozen grant-funded programs. Our largest right now is we are a lead health home in New York State. Our Adirondack Rural Health Network is the regional planning entity for the region. Our 80K Wellness is funded through the Cabrini Foundation, which is a program that helps us with social determinant referrals. And we also, through the EASE program, do assisted enrollment in the region. We were one of the 25 disrupt PPSs in New York State when that program was running. And so, a very population health focused organization with a little bit of larger geographic footprint than the Adirondacks ACO, but the counties and regions within the Adirondacks ACO are all included in the AHI region, and certainly overlapping partners and again, similar footprints. Next slide, please. So, a little bit more about AHI. There are 5 member organizations of AHI, 4 of which participate in the Adirondacks ACO. The total members of 4 hospitals, 1 large FQHC, and then 3 hospitals, 1 FQHC, as those participating in the Adirondacks ACO. Next slide, please. So we went through a series of shared service agreements over a couple of years, and then we brought this even closer in March of 2021, where we had the ACO and AHI go through an affiliation step, where AHI became the sole member of the Adirondacks ACO, and we went through a reconstitution of the governing board. So we had a lot of the same people in the region sitting on both boards, same organizations, same individuals, taking a lot of time, within the meeting structures and so forth. And we wanted to widen the participation level, and bring in other portions of the organization. So what we did in the reconstitution is we focused on the ACO board of managers to be very clinical leadership, operational and finance driven. And on the AHI board of directors, it's much more broader community and CEO level representation. And again, 2 fairly small organizations, AHI about $25 million operating budget after DSRIP, ACO about a $10 million operating budget, bringing those together in what we call a combined operational unit. And you can see in the right-hand box there, the number of shared roles that we have between the 2 organizations. So in addition to myself as the shared CEO, we have a CFO for both organizations, a vice president role in the ACO that also serves some operational roles at AHI. We have a director of quality, director of partner engagement, director of data analytics that serve both organizations, as well as an integrated analytics team that have staff on both sides, but share resources and serve both organizations. So, in a success standpoint, we've really been able to drive down the operating expense overhead of the ACO and push it much closer to a sustainable model by leveraging the work of AHI and the DSRIP program. Next slide, please.
Yep. And just a friendly reminder, 2-minute reminder, Eric.
Okay, I'll try to go quick here. So just to put this in action, the affiliation in action. So this is an example of how the ACO structure works. We have 4 work groups, all supported by the data analytics team and shared support between AHI and ACO roles. Those 4 work groups roll up under the POP Health Advisory Committee, which has broader representation than just the members that are on the respective boards, and also a pretty typical finance committee and compliance committee. And then to really illustrate some of the gained efficiencies by bringing the 2 organizations together, the red bar or red line at the bottom shows the progress of the budget gap for the ACO over the years. So in 2018, we had about a $500,000 budget gap. And our step was the budget gap was the first thing taken out of any distribution of shared savings back to the partners. And you can see as we roll that forward into performance year 21, there was no budget gap, and we're projecting no budget gap in 22 and 23. And then in 2020, the green bar represents the first time that we had shared savings on the MSSP program. Collectively, over these 4 years, we've been able to distribute about $11 million back to participants in shared savings. And again, by having driving down that budget gap, it pushed those dollars right back out to the participating providers. So I'll go very quickly on the last couple to be cognizant of time. Another success story was some work on the data analytics platform. We went through a very kind of typical process where we spent a lot of time, dollars, resources in a analytics vendor where we looked at it after a number of years and tried to match the output to the dollars invested, and just didn't feel that it was justified. And so we moved to a partnership with HRSA, which is the regional health, or one of the regional health organizations in New York State, leveraged the resources and investment in those RIOs across New York. And you can see the implementation timeline starting in the fall of 21. And we made this more of a joint project. So it wasn't just a project around managing the ACO. It was a regional project to manage both AHI and the ACO and provide data from a regional planning perspective. And then next slide, last two slides just illustrate how this client data warehouse project with the HRSA works. So we integrate claims and clinical data. So you can see the left-hand side of this just shows how the claims data comes together. Right-hand side is the clinical data within that secure environment at AHI, and then the HRSA processing that brings it all together. And then the final slide just shows the different pieces of reports that we work with our partners on and how those are distributed. Again, I'm pretty quick on those to make sure I stay with time. Great, thanks. And there's contact info for us. If folks want to reach out after the meeting, be happy to share more details.
Thank you, Eric. And now Dr. Mueller.
Okay, my task is to pull us out to the 30,000-foot level and take a look at the national picture of where we are, particularly with Medicare accountable care organizations. And let me give you a few overview themes, and then I'll go through the short slide deck. Theme one is there has been tremendous growth in the participating entities in Medicare accountable care organizations in the last 5 years. A little bit of stagnation in the total attributed lives for a couple of years. That is now turning to more attributed lives as well. Theme two, we can expect that to continue with new ACOs being formed, as well as the pattern we're seeing now is a growth among national and regional ACOs. Next slide. So the landscape federally is to move from categories 3, or going to categories 3 and 4 of a model from the HCP LAN, that's a Learning Action Network formed a number of years ago by the Department of Health and Human Services. So moving to categories where there is upside shared savings, as well as sharing in the risk in population-based payment models like the two you just heard about. The federal policy goal is to reach 100% of all Medicare beneficiaries in an advanced payment model by 2030, both through Medicare, traditional Medicare, as well as through Medicare Advantage, and in Medicaid. And the federal leverage there is letters out to state Medicaid directors, helping them understand how to move in the direction of the kinds of models, again, that you're hearing about today. Specific actions that have been taken is in the Medicare Shared Savings Program, a lot of new rules that just came out a little under a year ago that will be in effect in January of 2024 that I'll review in a couple of minutes. Other designs to shift downside risk to providers, including global budgeting going on in some states like Pennsylvania and Maryland, direct contracting, which is the ACO REACH model that you may have heard about as well. And as was the case explicitly in the Maine presentation and also embedded in the New York presentation, keeping the eye on the prize, which is the quadruple aim. Next slide. This is that HCP land model and those categories 1 through 4. The move is toward category 3B, which is advanced payment models that have downside risk. Much of the activity in rural America right now in the Medicare ACO world is in 3A. And you'll see with the new rule that rural providers that are new to ACOs are being allowed significant time to stay in 3A before transitioning to 3B. But the ultimate objective is to get over to category 4, where payment is population-based and no longer encounter-based. Next slide. This is the overview of where we are nationally in the shared savings program in Medicare. In terms of the number of ACOs, it plateaued in 2018, pre-pandemic at 561. 2018 is coincidental with a change in the rule governing ACO agreements to compel ACOs to transition more quickly to downside risk. That did result in non-renewals of a fair number of ACOs between 2018 and 2021. Ultimately, the number in 2023 now is 456. But interestingly, the composition of the ACOs has changed. In that now there are more that are in the low revenue. Those are low revenue, meaning Medicare is a modest share of their total patient revenue. There are over 2,200 rural health clinics participating, 467 critical access hospitals. The two-sided risk models include over 300 of those 456 ACOs. And so the composition has changed and is evolving. Next slide. This is the map of in 2023 from the CMS website of rural participation in ACOs, defined in terms of beneficiaries who have been assigned to an ACO. In your region of the country, those are predominantly ACOs that are located in the same state where the beneficiary is living. I point out the assignment or attribution when you look at some of the North Central and Northwest participation in North Dakota, for example. That may be beneficiaries assigned to an ACO located actually in a state like Arizona or Florida where they winter. And not really an ACO back in, say, again, North Dakota. Next slide. I said there were changes underway in the rule that was adopted in 2023 that will affect ACO participation of, again, new or inexperienced providers, people who have not been in ACOs previously, or their previous ACO experience is limited. I won't go into detail here about the CMS definition of that, but those participants in ACOs will have a longer time in the basic track A, which is upside risk only, for up to 7 years. They'll receive an advanced interest payment and quarterly beneficiary payments. This mimics something called the advanced payment model that was tried on a demonstration basis. The demonstration was deemed a success. Now it's part of the program. Changes to the minimum savings rate to allow shared savings before the minimum rate is met. That will help, again, the small ACOs in particular who don't generate high savings in the first 2 to 4 years. It introduces a prospective trend to adjust how the benchmark is calculated, which again will help because you won't be penalized for having achieved great savings, and then the following year your benchmark gets adjusted because of what you've done. And it reduces the negative regional adjustment cap that's part of this calculation from 5% to 1.5%. Next slide. Other changes in the rule, adjustment for prior savings. So if you've achieved prior savings, those can be added back in, or at least a portion of them, into the calculation of the benchmark. Again, trying to take away the, in effect, penalty for success that can happen. Risk score growth cap adjustment. So this allows flexibility in how that is calculated within a 3% range. And then finally, a sliding scale for shared savings and losses to allow a percentage of savings when the quality performance. This is getting into the weeds a bit. Let me pause for a moment here. The shared savings calculation is based both on the savings generated as well as the score of the ACO on the set of performance indicators. And in those calculations, you could generate financial savings, but not see a lot of them returned because of the score and the quality performance. This is an adjustment to correct for that, particularly again with new ACO. So if the quality performance falls below the 30th percentile, previously you wouldn't get shared savings. Now you will if it's at least in the 10th percentile of 4 outcome measures. Next slide, please. You have a longer, did we go the wrong direction here? No, okay. You have a longer time in track A, up to 7 years. You get the advanced interest payment. I think we did go the wrong direction. So advance again. There we go. That was all at the federal level. I said in the introductory slides, both Medicare and Medicaid are moving in this direction. So Medicaid payment policy, and you heard that particularly in Maine with some of their examples, includes requirements built into MCO contracts. So many of the states around the country now, over 30 actually, are operating their Medicaid programs through contracts with managed care organizations. 29 of those states require MCOs to implement value-based payment models. So those are states in which the state is no longer the direct payer of providers, the MCO is, but in the state contract with the MCO, the terms of the contract say the MCO is going to use value-based payment and how it pays the providers to that provide care to Medicaid beneficiaries. 26 of those 29 define the types of the VPP model, and the most common definition is use a shared savings methodology. State regulatory policies also facilitate or inhibit change, even if it is an MCO. And the CMS role that I alluded to earlier is through transmittal letters. In January of 2021, the letter detailed opportunities states have in the Medicaid program to address social determinants of health. And then 2 years later, CMS provided more specific guidance on how states could take advantage of waivers in the Medicaid program to directly fund activities related to social determinants of health. The leading example in the literature is allowing Medicaid expenditures to go out to agencies providing housing assistance to Medicaid beneficiaries, recognizing the obvious relationship between housing and health. This was an overview of predominantly Medicare SSP with a slight laying in here in this last slide of the state elements. Next slide. So that concludes this presentation. I included a slide for further information from some of the Rural Policy Research Institute activities, our health panel that has a summary document of the final rule, and the changes in SSP, our Center for Rural Health Policy Analysis that tracks where the providers are that are engaged in Medicare SSP. We'll be updating that within the next couple of months. and our rural health value site that includes a lot of technical assistance, tools, and also profiles of innovation occurring around the country. And then the final slide is my contact information. So thank you for your attention. I hope you found the overview helpful.
Thank you, Keith, and thanks to Sandy and Eric as well. If you have a question, please feel free to enter it in the Q&A. We did have some questions earlier, and Sandy, thank you for answering some of those in the Q&A section. If you have a question, we have about 14 minutes for questions. Please enter them in the Q&A, but I'll throw one out to our panelists, whoever would like to answer it. But how is your ACO supporting our rural hospital colleagues to maintain viability? And again, you know, a lot of research and articles on the sustainability of small rural hospitals. So how is your ACO helping to maintain that sustainability or viability? So I'm not sure anybody wants to take that one on.
Go ahead, Eric.
Okay, I was going to give one example of we're actually going through a transition currently where our chief medical officer at the ACO is phasing into retirement, and so we were scouring, you know, how we're going to fill that position. And at one of our critical access hospitals, a physician who had an interest in taking on more of an administrative role. And so we're working through that transition now to enter a contractual relationship with that critical access hospital to take on some administrative functions at the ACO. So, you know, providing some support for that salary and of a physician at a COB. So that's one example.
Great.
Yeah, and I would echo Eric's example, right? The ACO structure, the network structure, it allows for that sort of nimbleness to respond to needs of any of our healthcare organizations in terms of day-to-day sustainability or structure. I think more generally too, there's a common myth, and I don't know if it's so much a myth as it is an oversimplification, that value-based care work runs antithetical to hospitals' bottom line, and that the only way to realize success in these agreements would resultingly lead to an impact on hospital revenue. But the fact is that there's plenty of work that can be done by the ACO, by a value-based care structure, where the interests of the hospital in terms of financial sustainability align very well with the work of the accountable care organization and improving population health. So I think about examples like, you know, we focus a lot of our time and energy around avoiding and preventing avoidable readmissions. Right? That's something that the hospitals are financially aligned in preventing readmissions. Avoidable readmissions. We focus a lot of effort around transitions of care. There as well, hospitals are financially aligned. We can reduce the length of stay for a patient and ensure that they are transitioned home and able to stay healthy at home and avoid readmission. That's an aligning effort. And then last, I would just focus on much of the work that the ACO does around addressing gaps in care and around addressing preventive health needs. You know, that results in downstream revenue that can be a lifeline for these rural hospitals. Things like mammography services or colonoscopies that we know are necessary and really have an incredible impact and effect on patient outcomes, and also act in furtherance of bolstering the financial health of those hospitals.
Great. Thanks, Sandy.
Play off of what Sandy just said a little bit, that there are two sources of revenue for hospitals participating in ACOs. For rural hospitals, one of those are the services that Sandy just described that are related to primary care services that you would expect to have happen in a hospital. And the other one that I guess is so obvious we don't start with it is the shared savings. That when you are successful in the ACO arena, you will receive a check. And when we're talking to hospitals around the country who have participated in ACOs, that tends to be one of the first things they talk about is financially it took us from a fee-for-service model that was headed in a negative direction to at least a balanced model because of the shared savings checks that we're getting.
Great. Thank you, Keith. And maybe an opportunity for our panelists to speak to one significant achievement or outcome that has been delivered to a rural community as a result of the ACO's collaboration with the local healthcare providers. So maybe an opportunity to talk about some successes that you've seen in your marketplace, and then Keith, perhaps from a national perspective.
I'm happy to lead this one off since Eric was kind enough on the last one. So on this one, I would say the examples of success all tie back to a common theme, which is that one of the implicit values of our accountable care organization is that a patient's health outcomes, that a patient's mortality should not be dictated by their zip code. And so much of the work that we do is around ensuring that not only the quality and caliber of care is consistent across, but also that access to care is consistent across, regardless of where the patient's located. So I think about some of the interventions that have been most meaningful there. It's things like many of our organizations partnering in an e-consult model where you have specialists who are now at the ready to provide essentially curbside consults to primary care providers. It gives patients who otherwise would have traveled many hours to access a specialist, who may have had social determinants of health barriers to being able to access that specialist, real-time access in the same way that someone in a more urban area would have. So interventions like that, interventions that focus on, many of our organizations really struggle with recruitment and retention of MAs. And so having the pre-visit planning service that we have in place, it takes a significant amount of work off of the MA team members, and it allows for the practices to continue to run. And again, for the provider team to go into that visit with the patient fully prepared for all of the aspects of care that need to be addressed during the visit, even if they have some gaps in terms of MAs or with MA turnover.
Yeah, for us, I think it's another illustration of how leveraging the AHI and ACO relationship has worked in the region. As we heard different challenges, then we were able to pursue some grant funding that address some of those challenges. So I'll give two examples of two HRSA grants that we have. So we have a care collaboration grant that really focuses on transitions of care. So that was listening to some of the challenges in the hospitals, and we're able to secure a grant that actually initially ran through a hospital, and then we administer it. And then another one was to look at some workforce challenges and training initiatives around training care managers. So again, more than just the ACO relationship, bringing in that grant-based and grant-funded organization to bring additional resources to the region to address some challenges.
Great. Thanks, Eric. Keith, anything to add?
Well, sort of a big picture view again, since that's my role here, is, and we've seen this around the country again, that the ACO, by nature of all the kinds of services that you heard from Sandy and Eric, is strengthening a relationship between the local healthcare delivery system and the patients/residents of their community. And so a greater sense of loyalty and satisfaction with local providers, which means you're keeping the care local that can be provided local because you've linked with things like the e-consult that Sandy mentioned. So I know I don't need to go somewhere else. I know I can start with my local provider. And again, that both drives up retention of revenue locally, but more importantly, get you closer to the other elements of the quadruple aim.
And we do have a final question, Sandy. I see you're answering it, which is great, but I think this goes back to, Keith, the slide you had in your presentation. The question is, this is probably simplistic and naive, but why not go straight to category 4 integrated finance and delivery models and skip all of the incremental models?
Well, if I could just wave the magic wand, I agree. And we have some examples of organizations that have done that. This would be the large organizations that have their own health plans like Kaiser, Geisinger in your region. I think I've always maintained the challenge is getting to a point where both the payer and the provider of the service are satisfied that they know the correct per member per month calculation to have a true global payment budget or a global budget based or a use of per member per month. I think the ACO activities are critical in transitioning us to that kind of knowledge base and all the use of the data. But I don't think both the payers and the providers are going to be comfortable until there's a sufficient amount of experience with models like what Sandy and Eric are doing.
Well, thanks, Keith. We have about 4 minutes left, so I'm going to ask each of the panelists to kind of look into their crystal ball. And, if you had to project out 5 years from now, where do you see the ACO structure, the global budget structure? Where do you think the industry is going to be moving, and how will that impact your specific region? So I know I tossed that out to folks, didn't give you any, but just would appreciate your kind of forethoughts.
Am I batting lead off again on this one then? All right. Yeah, I wish I had a crystal ball. And I don't know where it'll land, but I think what we are all facing is, I think Keith had mentioned it in his presentation, some of the presence of these national type ACOs into the market. And so, we have organizations that are knocking on the doors of our participants and offering up some options of avoiding downside risk. And so, that really is an attractive thing that some of our participants listen to. And we're trying to figure out how we fit into that. So can we be part of that, or is it a competition thing? So I don't know where it's going to land, but it certainly is something that we are really starting to wrestle with over the last 12 months of how to relate to and integrate with these national type ACOs that are looking to come into the rural markets.
Yeah, I think for us, that's an ever-present, it's a concern, I think. The concern is that may lead to the, corrosion of the very intent of the ACO, there's a reason that the large nationwide entities are interested in these partnerships, because there's financial interest, right? And so the very goals that we set out in terms of population health and focus on responding to the needs of the community in a way that align with value-based care work are potentially corroded by that. It's a potential risk. So I think we very much are concerned about that. As Eric said, it is very appealing because it essentially removes risk, right? That the entity takes on the risk for the organizations in most models. I think for us, the resounding message that I see, and in particularly in Keith's presentation and some of the key changes from 2023 to 2024 in the shared savings program, it emphasizes and highlights the administration's continued identification that ACOs are an important part of reducing the overall cost of care, and that there is opportunity in this model to continue to grow and to expand upon that work. So I'm looking forward to further emphasis and opportunities to partner with the administration, with payers on improving health outcomes and reducing the overall cost of care.
Great. Keith, we'll give you the last minute.
Okay, I would take the future by the 3 types of payers out there. I think with Medicare, what Eric and Sandy are saying is absolutely true, that it will continue to grow. And there's a wild card here with equity investors and what they might do on a national basis. I think with Medicaid, we'll start seeing some sharing of lessons learned across the states. And I think the big player in this is commercial, and what are they going to do? And my recommendation to a lot of rural America providers is get into strong relationships with your state or regional commercial carrier, the largest ones. So you're negotiating contracts with your terms in mind, Because at some point, they're going to either go to a third party like one of the national ACOs or someone else, and we're going to lose some of that local control that is so valuable in rural.
Great, thank you. Josh, I'll turn it back to you.
Yeah, and thank you everyone for being here and engaging with your questions and answers. And Keith, Sandy, Eric, we appreciate you presenting a fantastic job today. Just want to make you aware, we do have our next webinar series on June 27th, a Tuesday again from 10:30 to 11:30. We knew better not to have it the 4th of July week that Tuesday. So on that note, we'll leave you, and thank you once again for your coming out. Thank you.
Thank you. Thank you all.
Thank you all.